to the 67th Conference on Senior Engineering Design, hosted by the College of Engineering and Applied Sciences. And this session is hosted by the Department of Industrial and Entrepreneurial Engineering and Engineering Management. I am personally honored and humbled knowing that I have been fortunate to attend all 67 conferences. It's been wonderful. We're very pleased you are able to be with us this morning. This is our second virtual engineering design conference, and we are happy that technology allows all of us to be together. There are several groups that we would like to extend a very warm welcome to, and that includes fellow students, faculty, visitors, friends, alumni, and project sponsors. Thank you very much for being here this morning supporting these students. Another group that we extend a particularly warm welcome to is family members of the student presenters. While it's not always possible for family members to join us, we are especially pleased when they can. This morning, we would like to recognize, and I don't know, Dana, do we have them turn on their cameras so that we can recognize them? Or
yeah, if they're willing, that would be wonderful.
We have Dwight and Bridget Ross for Jasmine and Nana Adi Delahousie. Are they here? Can we see them? Very good. Thank you very much for attending. For Morgan, we have her parents, Dwight and Brenda Croner. Dwight and Brenda, thank you so much also for attending. Very pleased that you're here. We also have the WMED sponsors, Chris Sickles and Nareen Kumar. Thank you as well very much for attending this morning. These students, almost engineers, are very thankful for all the love and support that they have received from so many people that have made it possible for them to be here today presenting their projects. This is indeed a very exciting and proud day for our senior industrial engineering students. They have worked very hard on the projects they will be presenting this morning, and we think you will be very impressed. Our first project this morning is supply chain improvements in healthcare. Team members Jasmine Fales, Morgan Croner, and Javier Navarro.
Thank you, Dr. White. I'm going to pull up the screen right here.
Okay. Good morning, everyone, and welcome to Healthcare Supply Chain Improvements, presented to you by myself, Jasmine Fales, and my teammates, Morgan Croner and Javier Puntz. During this presentation, we will be walking you through our entire project, starting with our background and our advisors. Then we will be discussing our objectives and our areas of opportunity. After that, we will go into some details about some solutions that we found from our opportunities. And this will include our data, our organization of data, our future demands, and calculating our reorder points and our order quantities. And then lastly, we'll wrap it up with some potential savings and recommendations. Our project was done at WMED Clinic, which is located on Oakland Drive campus, and it consists of residents and fully licensed physicians. So anyone can seek care from this facility since it's both an academic and clinical department. Our advisors for this project is Dr. Azim Hushar and Dr. Bob White, who are both professors and advisors in the Industrial Engineering Department. And our company sponsor is Chris Sickles, who is a clinical nurse manager at WMED. Our project objectives is to improve the clinic supply chain by optimizing data tracking and creating visibility of usage.
So first we want to talk about the current order process at WMED. So every week nurses go into the exam rooms for a restock. The exam rooms are where patients go to see the doctors and nurses, and they restock items that are commonly used like gloves, sanitary items, and needles, things like that. First, there's a visual inspection done as to what they need. They go back to the stock room And before restocking the rooms, they check the expirations of all the items that they're gathering to make sure everything is within that expiration date. And then they check the inventory levels of all of the items. If they find that the inventory levels in the stockroom are low, they can then place an order. Something you're going to hear throughout the presentation is that anyone can order anything at any time in any amount. And this is going to prove to be a big issue. So once that order is placed, it goes to Chris and she reviews and approves those orders. While doing that, she tries to manually consolidate them so there's not as many repeat orders. And then once that order is placed, they then put it in the stockroom. So we have three main areas of opportunity. The first one being the ordering system. As I described, it's a bit convoluted. And you're going to see a lot of redundancies within it. Next is tracking inventory. Currently, there's no way to know exactly what's in the clinic at any given time, what the expiration dates are, or standard ordering procedures or standard ordering amounts. And then finally, bulk savings. We're going to be talking about potential savings while being able to group the orders.
Okay, so we're going to go into the first area of opportunity that we have, which is the ordering system. So number one, remember that everybody can order. That doesn't mean that they can just place the order and it will be provided, but everybody can place the order and then take time from Chris. It can be a little bit of an issue that there's missing or incomplete data because logs for purchase and usage are not kept in the clinic. No one really knows how much of each supply is available at any time, and that is because supplies can be moved around into different rooms. And if the nurse doesn't see them, they think that there's nothing available. Order amounts are not particularly optimal, and this is because economic order quantities calculations are not set. And personnel doesn't really know when to order new material. Since there is no set minimum and maximum, it's more of a, oh, I see that there's not enough of this, they order more. And this can cause delays because of things like lead time. Now, where the clinic stands right now is that they have a new organizational management system called NetSuite. Now, NetSuite is currently being set, which means that it is not available for the department yet, but it will be available in 2021. This is where we can help develop the data that will be input into their system when it becomes available. For that, we have to choose the best ordering system for the clinic. It can be either centralized or multi-point, and we found that the clinic would benefit from a centralized system because of its organizational methods.
Our second area of opportunity is tracking inventory. And we understood before ordering, it is important to know how much material is already in the stockroom at any given time. And this can really help with managing costs and controlling the costs so that way the clinic is not over or under purchasing. This can also help with environmental impact because any item that is wasted due to expiration dates or other factors have to be disposed of correctly. And this can also lead to waste reduction in the future. As well as this can reduce the liability by making sure that any item is not out of stock when patients need them or any expired item is being used on a patient.
So then our third area of opportunity is bulk savings. So as Jasmine and Javier described, there's really no schedule for ordering. And that means that there's really no opportunity to group orders other than what Chris is doing manually right now. There's a couple different benefits to order quantities. There tends to be a supplier discount. So the more you order, the less you pay, and reduce shipping costs. So if you're placing less orders overall, you're paying for shipping less. And then finally, reduce setup costs. So that could be reducing the time it takes to place the orders, consolidate the orders, and also restock the rooms. We're going to see three different types of grouping available. An example that we're going to keep referencing gloves. First is individual grouping. So if the demand is really low for this product and it's sold on an individual level, that's how it can be bought. This tends to be for non-disposable items that are really expensive. Next is automatic grouping. So even though you might want to only order 25 gloves, the size of one box is 100 units or 50 pairs. So that automatically bulks the order because you have to go to that smallest size. And then finally, the actual bulking. So for this example, there are crates rather than boxes. And in one crate, there are 10 boxes. So rather than ordering 10 boxes individually over a span of time, you can place one order of one crate and receive that same amount. Next, we're going to talk about what solutions are and how we implemented them. First, we had to organize the data and then recognize the key products. These are products that we spent, that the WMED clinic spent the most money on and most frequently buying. Next, we forecasted their usage for 2021, both with and without the COVID pandemic. We then identified the order sizes and reorder points, and then looked at opportunities for bulk ordering and cost savings. So first, when it came to organizing the data, we received the purchase data of the past 2 years from Henry Schein, which is one of the main suppliers for WMED. We found that the raw data and the first word descriptors were not very useful. It seemed like they had 50 different ways to say needle or syringe or Band-Aid. So instead, we utilized the categories that were given to us by Henry Schein. So each item is categorized under several different category levels. Level 1 mimicked a billing center. So for example, here, medical and surgical supplies, it could also have been office supplies or things like that. And once you get a little bit further, the items can be categorized into any of these groups as a level 2 category. So that's Band-Aids and tapes, gloves, orthopedic, things like that. And we use this because it was a really great descriptor, and it seemed like there were only one type of item in most of the descriptions. And you also didn't see any bleed over. So you didn't see any gloves in orthopedic or wound care in educational materials, things like that.
So the team decided to move forward with category 2 to define our items. And we applied an IE tool called 80-20 rule because 81% of the clinic's budget was actually spent on 20% of the materials used. And then we decided to divide the top 80% into 3 different categories, which group A represents the top 50%, group B represents the top 15% of cost, and group C represents the last 15% of cost, grouping all together to 80%. To start analyzing these items in these groups, we decided to use a technique called linear regression. And this really helped us understand the trends in demand. And it's really important because the current ordering system, like we stated before, that anyone can order anything at any time. And this really leads to over and under ordering, organization hassles, as well as inconsistent orders. And to prevent these things from happening, the team received 2 years of past purchasing data to analyze for that linear regression model. And then we estimated normal usage levels and then defined good inventory levels for each item. And then lastly, we projected our demands to calculate our reorder point and our reorder quantity to forecast for future needs.
Okay, so when we received the data, we analyzed it, and the very first thing that popped up is that it was very clear that there's a strong effect of the ongoing national and global events regarding the order sizes for 2020. Since this is the only data that we have available, we had to try and extract as much information from it as possible. So this is why we devised a method to look at the data and decide if there is salvageable information from the 2020 period. So this is how we did it. First, we would take the data and ask if there is statistically significant difference between the sets of 2019 and 2020. If not, then we can use all of the data. If the average purchase size for 2020 is too high, then we ask if we can normalize it, and we try to do it with a multiplier. If we can normalize it, then we will use it, but if not, we will still attempt to obtain some information from it. If we find seasonality across both sets, then we can obtain both seasonalities, mix them together, and get a more precise seasonality. But in the worst case scenario, we find no seasonality, the data for 2020 does not follow the trend of 2019, so we end up using only the 2019 data, which is from the normal period of time. So this is an example of the process being applied to gloves, which is one of the main categories of items. We can see how using the multiplier, we were able to normalize it. And then we can also see how the seasonality is still there. There's going to be more on that on the next slide. But for now, we can see on the graph on the left, the numbers on blue are 2019. The orange is 2020 original numbers. And then on the graph on the right, we can see the numbers for 2019 in blue and the normalized numbers in 2020. And we can see how they play very nicely together. Now we also have the seasonality, and it was retained through the normalization. On the top graph, it shows the non-normalized 2020 data. And on the bottom, we have the normalized 2020 data. And it seems that for this particular product, there is a quarterly seasonality. This brings us to the deliverable form of the forecast. We can see the original data period in blue and the normalized 2020 in orange. and how they play nicely and follow the trend. We can then see the forecasted amount in green for the year 2021. These values are good in case that the pandemic ends in the beginning of 2021. But since we are not sure that the pandemic will end, then we also devised an optional 2021 forecast, where we use the original data of 2020, seen here in orange, to determine the trend for 2021, where the contingency may still continue. And this is useful for the clinic because they can switch between both systems depending if they feel that the pandemic has been contained or not.
So now we're going to talk about order quantity. This is an economic order quantity. What that means is whenever items hit a certain reorder point, we want to place the same size order every single time. Prior to this, when nurses saw that they were low on inventory, they could place any size order that they deem fit. And what one order might be to one nurse is small, it might be large to another. So we wanted to standardize that using this equation. So this example here is using the 2021 data for gloves without COVID. So we saw an annual demand of 18,888. Please note that these are individual gloves and not pairs. We then multiplied that by 2 and multiplied it by the cost per order. So this is our setup cost, and we deem that to be about $10 for shipping, and also considering the amount of time it takes to place the order and then consolidate and restock the rooms. And we divided it by the holding cost. So when it comes to inventory, you are technically losing money. It costs money to hold any items within stock. And in this case, we figured it to be about 1 cent per glove. Once we did all of that math, we found an EOQ of 500 gloves or 5 boxes. Next, we can talk about reorder point. So I mentioned that in the previous slide. Reorder point is the point of inventory that an item can get to that then triggers a new order. So for this example, we used type 1 order service level. And we used order service level because we cared more about the times that they were out of gloves than the amount of gloves that they were out of. We used a 99% service level because realistically within the clinic, they can have no shortages. If they had a shortage of gloves or needles or sanitary items, things like that, then they aren't able to perform the exams on the patients, and that's just not realistic. So we had a very, very high service level. Found it to be normally distributed, and this is our reorder point equation. So first we took the demand during lead time. Lead time is the time that it takes between the day that the order is placed until it arrives at the clinic, and that was about 5 days. We then found the demand during lead time. So we took the daily demand, multiplied it by the lead time to receive that. We then found the Z value, and that's based on our 99% service level, which is 2.58, and multiplied it by our standard deviation, which we assume to be 10% or 25.8 gloves for the demand during lead time. This gave us a reorder point of 326 gloves, or just over 3 boxes. So as soon as the 4th box is being used, we know that we have to then order or place our next order of EOQ. So now I'm going to talk about possible bulk order discounts with the glove example again. So as I'd stated, we have an EOQ of 500 units, a daily demand of 52, a lead time of 5 days, and a setup cost of $10, and we assumed a bulk discount of 10% through Henry Schein. Next, the automatic sizing. So as I had mentioned a while back, there are 100 units per box or per case in this instance for gloves. If you were to go one more step and order 1 crate, there's 10 cases per crate. So that's a total of 1,000 units. So if they were to follow the EOQ that we deem fit to be 5 boxes or 500 units, they would place 32 orders throughout the entire year. However, if they would go to the next size up and order a crate rather than boxes individually, they would only place 19 orders. So with our savings, we would see a discount price savings about $108 annually. And this is small because they're not ordering more than what they need, really. What the disadvantage of bulk ordering is that you can order quite a bit more than what you need, and that increases your inventory costs. Because they're ordering around the same amount annually, you'll only see an increased inventory cost of $1.71 because the holding cost is so low. And that also means that the discount price savings is fairly low as well. The other cost savings is with order reduction. So as I said, there are 32 orders placed every year with the EOQ of 5 boxes. And that means that you're paying for shipping 32 times every single year. And you're also taking the time to place the order and restock the rooms 32 times. But if you were to bulk order, you're only placing 19 orders, so only paying for shipping that many times and only restocking the room that many times. So we see a savings of $126 annually with that. That gives us a bulk order savings of $232 every year. This seems like a small number, but please note that gloves was in the C group. So it's one of the low cost items considering the 15 total products that we looked at. So those 15 products added on top of each other does add up to be quite a bit of savings.
Based on our findings, the team has a few recommendations for the clinic to continuously improve their supply chain. First, by establishing a pull system to maintain consistent inventory levels. But while they have a manual system, it is best to use Kanbans, like the one shown in the bottom right-hand corner, to order items that are used more frequently than expected. And the Kanban that is in the bottom right-hand corner would be placed in the middle of a certain amount of items to distinguish when to reorder that item. And if stock is below minimum amount and that Kanban is gone, then the person that is in the stock room will know that somebody has already purchased an order to replenish that stock. And then this also goes along with making minimum and maximum labels. So that way it is clearly stated for everyone in the stock room how much stock should be of that item. And then also updating the ordering system to utilize the forecasting techniques that the team created for the clinic. And then utilizing the bulk purchasing to save tremendously. With the work that has already been done for the team, we were able to provide when to order, how much to order, and then how much bulking should they do for those top 80% of cost items. And this is in the case of if the pandemic was to continue, as well as if it was not to continue. And with all of these things, the team was able to calculate a total savings of over $23,000 if COVID was to continue, and a total savings of over $2,000 if COVID was to discontinue. And you might see a big difference from this because the clinic is constantly buying new materials to serve for that pandemic and make sure that they are helping everyone that comes in that needs help. And these numbers can be seen year over year to continuously improve the supply chain of the WMED clinic. So thank you for your time. And are there any questions?
We have time for a couple of questions. If any of the people want to ask them, anyone have a question, just turn off your mic and go ahead and ask.
First, I would like to thank Dana and the professors from WMU and our brilliant students who worked with us to help us figure out this process. So thank you very much for that. Some of these recommendations are best practices, and this is a great opportunity because sometimes healthcare systems are a little disconnected with the best practices that's happening in the engineering world. So thanks for bringing those expertise and help us streamline the process and identify these opportunities. So thank you for that. We look forward to implementing these, and great work by all the students. Thank you.
Thank you so much.
Thank you, Narain. Anyone else? Anyone have a question?
I have a quick question, actually. And just for your forecasting, it says that you guys used linear regression. Why linear regression? Was it just for simplicity's sake, or was that the best model that fit your data? Or I was just looking for some rationale on that.
Yes, the reason why we stayed with linear regression is because there was so much going on that reading what things affected with multiple regression would have been really not significant, because we couldn't really tell, okay, COVID is doing this, but the numbers of COVID are showing up, tests are up, tests are down. There was just so much going on that the best way for us to ensure a reliable source of data was to make it as simple as possible and not input as many things from the exterior, because they are not readable right now with COVID going on.
All right, perfect. Thank you. And then one other question. How did you calculate your holding costs? I know, Morgan, I believe you said that it was a penny per glove, since you're using the glove as the example. How did you guys come about that?
Yeah, so we that was a function of the unit cost itself. So we did 10% of our unit value. It's kind of difficult, of course, to come up with a holding cost without a lot of information, but that's what we assumed.
All right, thank you. That clears it up.
Thanks, Luke.
Anyone else? We have time for one more. Anyone?
White, Dr. White, Dave Null from Covenant Healthcare in Saginaw. Not necessarily a question, but just a comment. Really good work. I am a vice president of the hospital here in Saginaw, and our supply chain is just fraught with cost that just leads to safety issues and variability in outcomes. So this is just a great area of focus and a great area of focus for healthcare to again apply the the IE technique. So great job and very good work by the students.
Thank you so much.
Thanks, Dave. Thanks for joining us this morning. All right. Well, thank you very much, everybody. Nice round of applause for the students.
There's a little reaction button down at the bottom. You can give applause or whatever you want. So look.
I can still applaud.
You can do both. Oh, we got thumbs up. Thank you guys.
All right. We'll take a couple minutes break and then we'll begin our second presentation.